I've been asked to talk about immunomodulation in sepsis and where are we. Sepsis is one area which is very vast. Lot of advances have been going up, lot of tests, as I said, about the microbiological diagnosis, lot of newer antibiotics also into the pipeline. And we really need to see, before understanding what are the new immunomodulating therapies, we'll just consider the definition, the introduction, the epidemiology, the pathogenesis, and the newer approaches and the confusion. Everybody of you know that sepsis is just a body's response to that infection, and it injures the own tissues and the organs, and it can definitely affect multiple organs. It can give rise to sepsis, septic shock, severe sepsis, multiple organ failure, and these can occur because of different insults. It may occur because of trauma or because of some viral pneumonias, or it may also occur because of some bacterial infections. And sepsis is one of the leading cause of death in the United States as well as in India, and approximately about 2.5 lakh people dying because of sepsis. And almost a study reported that 68% of the mortality was mainly because of septic shock, and these patients were hospitalized outside the intensive care units, and the mortality was about 55% for those patients who were admitted into the intensive care unit. Certain terminologies like SIRS is outdated. It was one of the concepts which were being used, and just to say that these have been out. They consist of tachycardia, tachypnea, respiratory rate, but this has now gone up, whether it is sepsis, severe sepsis, and then septic shock. So SIRS is practically out, and as I said, it's one of the leading cause of mortality. This is there worldwide, and this also affects people, those who are immunosuppressed, and these people, there is no specific racial discrimination as to which patients are very mainly affected. And the primary site of infections, most importantly, cannot be seen in almost about 10% of the patients. And majority of the times the infections are the lungs, the abdominal, the urinary tract infections, soft tissue, or the other known infections. And you can see that definitely the septic shock mortality, as you progress from severe sepsis to septic shock, the mortality rate goes on increasing as you go high up the ladder or up to the triangle. And the epidemiology, whether it is caused whether by a fungi, is comparatively quite less, but those chances, again, mortality, if not identified and treated, they also go up increasing. And the bacterial infections, whether they're gram positive or gram negative, the chances of mortality, if not treated, are definitely going to be on the higher side. So before understanding into the immunomodulatory therapies, whatever infections you occur, whether they are gram positive, gram negative, fungi, viri, ultimately the host response is the one which is there, and there is again a host immune response. And this mainly because of the liberations of the sepsis, there is a large amount of liberation of endotoxins as well as the interleukins and the cytokines, and as a result of which there is the host response is the ones which is mainly gets affected, and this gives rise to inflammation, or the inflammatory markers get released, and they are the ones which give rise to the capillary leaks and ultimately give rise to organ damages or sepsis. So usually what infection, usually whenever it occurs, as I said, it is mainly the endothelial dysfunction which is occurring, and that endothelial dysfunction is again going to give rise to infections, or it can also give rise to multiple organ failures, and this endothelial dysfunctions is again going to cause liberation of the various cascade on the liberation of various cytokines and to produce a target organ damage. So ultimately these newer therapies which have been tried, or the newer therapies, they are the ones which are really targeting into the actions of these endothelial dysfunctions, and they are acting at these levels. It was similar to the way we had one molecule which was outdated, now no longer uses it as Zygris, which was initially used, but no longer it's been considered. But usually it's the physiology is where the alterations of the inflammations, and the action usually occurs at the endotoxin levels, and the anti-inflammatory mediators are the ones which are mainly playing the role. So if you see the host response, they have got the anti-inflammatory mediators in the form of interleukins. We have got the interleukin 1RA receptors, then the pro-inflammatory markers like the interleukin 6, the tumor necrosis factors, the nitric oxide, all these can give rise to leukocyte activations, and ultimately it can also progress if not treated, and if not hampered, then it can ultimately progress to sepsis and multiple organ failure. All these are the various new modalities are mainly acting as anti-inflammatory mediators or the pro-inflammatory mediators like which are mainly available. And this inflammation, as I said, is basically the initial response to any pathogens is the release of the pro-inflammatory mediators, and this is the one which allows the RBCs or the WBCs to reach the infected site. And subsequently there is an anti-inflammatory response which occurs, and this anti-inflammatory response is mainly an attempt to regain the hemostasis and to prevent the capillary leak. But if ultimately if the sepsis is not brought under control, the capillary leak is the one which usually starts occurring, then you ultimately progresses, and if not treated or identified, it may ultimately progress to the picture of sepsis and septic shock, or there is an endothelial dysfunction giving rise to a tissue necrosis factor, and also there is the inhibition of fibrinolysis, and which worsens and ultimately leads to progression of the cascade. So the role of endothelium is the most important. It releases the mediators of vasodilatations or vasoconstrictors. It also causes the release of the various cytokines and the inflammatory mediators, and it allows the leukocytes to assess the infection site, and it plays a very important role in the coagulation cascade to maintain the physiological equilibrium between the fibrinolysis as well as the coagulation. The drugs or the new immunomodulators are mainly acting into these different zones, and that's the reason why I'm just covering up certain aspects of these. While what happens in sepsis, there is a regulatory function of the endothelium is failed, and because of this there is extensive vasodilatation or reactive hypovolemia. There is a tissue factor release which also initiates the procoagulant state, and the microthrombi formation compromises the blood supply, and which ultimately leads to tissue necrosis and multiple organ failure, and there is also inactivation of protein C and suppression of the fibrinolysis. So you have to have a good amount of hemostasis, which is the inflammatory markers, that is the inflammation and coagulation, and the fibrinolysis, which is very important. So ultimately whatever happens, you have to see that the progression of sepsis is usually avoided, and you have to identify that the tissue injury does not progress further to a multiple organ failure. So whatever definitions you take with a systemic inflammatory response and all, which has been outdated, the sites of infections, as I said, it ultimately is going to progress if not treated into a septic shock. So the new modalities are the ones which are acting at these different levels. One is the interleukin 7. This is one family of the new immunotherapeutic agents which has got a great potential in the treatment of septic patients, is interleukin 7. This is a pluripotent cytokine. Let me tell you, I have not used any of these practically, nor have done any clinical trials also on any of these. So it's mainly a pluripotent cytokine which is mainly produced by the stromal cells, and it is mainly required for the T cell development, hemostasis, and it also and maintenance of the endothelial dysfunction. And the postmortem studies into septic patients have shown there is a significant apoptosis, and this induced loss of the cells in the innate as well as the immune system response is affected. And this interleukin 7, it only induces the hemostatic proliferation of the T cells during the times of lymphopenia, but also possesses anti-apoptotic properties, and these are therefore being considered to be used into septic patients. So basically the interleukins are mainly acting at different levels, as you can see here. They increase the production of the naive T cells, they also have increased the apoptosis, then also activate the T cells, and ultimately the interferon factors, and ultimately the cascade or these liberation of these cellular cytokines or the endotoxins, there is a suppression of this, and because of suppression of this, the endothelial dysfunction and the capillary leak is avoided, and therefore indirectly the cause of sepsis then comes under control. Another one is interleukin 7. This again is a murine model, and this was related, again therapy related to upregulation of the apoptotic protein, that is this is a theoretical discussion. What I am telling you is a BCL2 and the down regulation of the pro-apoptotic proteins, including the P53 upregulated modulators, that is a PUMA, as well as the BIM, and these were the ones which are preventing the apoptosis. And the other beneficial factors which were responsible with the help of interleukin 7, there is availability to reverse the sepsis-induced depression of the myocardial cytokines, and it is also one of the important activators of the monocytes as well as the macrophage. That is, the monocytes and the macrophage activating factors get stimulated, and there is an increased expression of the cell adhesion molecules such as lymphocyte functions, that is the LFA1, and the very late antigen, that is of VLA4. And the overall immune system stimulating properties of interleukin 7, that has been demonstrated to restore, and a delayed type of hypersensitivity response towards a known antigen, often a response strongly decreased into septic individuals. So this was one study which we found out where interleukin 7 was also being used, and it has also been implicated into various trials, mainly for viral infections, for examples into patients with HIV or in those patients with hepatitis and also into cancer patients. And the results also include that there was increase in the circulating CD4 and the CD8 cells, but not regulated T cells, as well as the increase in the spleen as well as the peripheral lymph node sites. But because of the broad stimulating effect of these interleukins on the immune systems, interleukins was mainly used into critically ill patients, and therefore they were said to be much more effective, and these were one of the certain clinical trials which have been used. Another one is similar to that. It is the interleukin 15 which has been used. It is again a pluripotent cytokine which is closely related to interleukin 7, and it is an essential natural killer development for survival as well as for sun function. Additionally, most importantly, it increases the NH cell cytotoxicity, and interleukins also support the hemostasis memory of the CD4 cells. But this again is mainly used into cancer chemotherapy or cancer immunoform of immunotherapy. And in contrast to interleukin 7 as well as interleukin 15, it has got more potent immunostimulatory proliferative cells on the NH cells or the CD4 and the T cells, and also the dendritic proliferation. So it is said to be much more stronger than the interleukin 7 what we studied. And this also has been studied into several load models of sepsis. This again has been seen that it decreased the apoptosis and the immunocompetent levels of the BCL2 level expression and improved the overall survival. And it has also been reported that interleukin 15 had a positive impact in reducing the sepsis-induced muscle wasting. More importantly, the protein loss which is occurring, the muscle wasting which also occurs because of the hypercatabolic state, that was also averted or reversed with the help of interleukin 15. This is the diagrammatic representation that is increases the cytotoxicity, clonal expansion, differential as well as the activations of it, and it also increases the proliferation of the proteins and the activations, and along with that it also increases the NH levels, which also further suppresses the release of the various inflammatory markers, and therefore sepsis comes under control. Another promising, which sometimes still being used into the hematologist side, is the granulocyte monocyte colony stimulating factors. This is again a cytokine which again stimulates the immune response in the septic patients. Neutrophils are one of the first lines for controlling these pathogens, and during sepsis multiple defects have been seen into the neutrophil functions have been reported, and because of the defects in the neutrophil, the normal immune system gets affected, and therefore there is an impaired clearance of the bacteria, and therefore there is also a reduced amount of oxygen or the species which are available, and therefore less amount of chemotactic activity. Thus it increases the inflammatory response, and thus there is increased chances of target organs or microvascular circulation gets affected, and as a result of which multiple organ failure sets in. And this GM-CSF has been reported again, and they have shown that impaired neutrophil function is the one which precedes the patient's susceptibility to nosocomial infections. And these also have been said that they have also known that there is an increase in the maturation, survival as well as the activation of the various colony stimulating factors, which indirectly also suppresses these inflammatory markers and the pro-inflammatory markers, and thus it helps to control the sepsis. Another one is the anti-PD-1 immunotherapy. That is again the phosphodiesterase coenzyme family members such as the B cell and the T cell, and that is the BTLA and the CTLA4. They have also been studied into septic patients. The expression of the CTLA4 is increased basically into CD4 and the CD8, and it regulates the T cell lymphocyte population into those patients who have underwent cecal ligation. This was an animal study which was conducted, and they had a cecal ligation, and then they were monitored for the proliferation of the T cells and into these patients. And as well as the postmortem study also, they showed there was an overall sepsis induced lymphocyte apoptosis and the survival of secondary fungal infections in the mice that were initially exposed. So basically this was again considered to be much more beneficial into septic, mainly associated with fungal infections. And this was again the various diagrammatic representations what I could collect as far as where and how the anti-phosphodiesterase 1 immunotherapy also is being considered. Another ones is the omega-3 fatty acids also were initially being considered. Initially as anti-inflammatory markers, initially intravenous glutamine was considered, but it's no longer being used into septic patients because there were increased chances of renal failure. Omega-3 fatty acids also have been considered for the antioxidant effect and the anti-inflammatory action. It does not reduce the mortality, but it is just known to reduce the length of ICU stay, and those also have been considered to be used. Similarly, initially fish oil was also considered to be used as, but again that again has shown detrimental effects and is no longer being used. So overall, if you ask me, it is beyond any doubt that sepsis is accompanied by considerable mortality, and that management cannot solely rely on a single administration of just pure antimicrobial agents. Along with that, yes, different therapies have still been considered, different therapies are still being used. We have also been using the new filters which are also now been available. They are also known to work sometimes. We have also using the ulinastatin also is being considered to be used, but again no longer used, only being considered only into pancreatitis kind of things, and various other immunomodulatory strategies in clinical practice. You require a detailed in-depth knowledge about that drug, how it acts, where it exactly acts, what is the pathophysiology and the pathogenesis of sepsis, because the sepsis pathogenesis of the pathophysiology is much more complex than what we actually really study of, and therefore appropriate immunomodulation, it requires the correct knowledge and at which stage and for which every patient and at which level it should be considered for use. Thank you.